Thank you very much, Steve, and Louis as well. And as Steve has said, we are the cardiovascular pathology, and we're funded by CRI, and this is vitally important because the service we provide in the UK is free of charge. And with budgets, as we know them, and Britex, etc., having a service that you get for nothing means people will take advantage, and I'm lucky to be based at St. George's Hospital as well, where we have our centre. Now, we guarantee, as Steve has said, we receive a heart with full consent from the family. They're aware of it, and they're aware it comes to us. And we do a histology, and we guarantee a turnaround of 2 weeks, 14 days, which is impressive when it comes to think that autopsies can be a year or almost 2 years sometimes before you get a result. And in addition, what is vitally important, which Gerardo has highlighted, is the fact that we enter all our cases into a central national database. In other words, every detail of every case is entered, including the heart, the background clinical information, the family information. This is very important as well. And recently, well, in December 15, we had a visit from the chief coroner. He's the boss of all the coroners. And as you know, the coroner system had not a boss. They could all do what they liked until about a year ago or 2 years ago. But this man tells them now what to do. So having his endorsement has been very important, as well as you can see there my clinical colleagues Sanjay and Mete as well. So it's important that I correlate closely with the coroner and with my cardiological colleagues. We don't act in isolation. That's vital when we're coming to following up the families as to the significance of our pathological findings, which Gerardo has already told you about. We get from all over, even Ireland at times, but mostly come from England. In other words, the whole of England. We're not just one region of England, we are all of England that we receive cases from. And this is what Gerardo has told you. The number of cases is going up. We're now gone to over 700 cases. So in other words, more pathologists, more referrals, less bias. We're now a truly, I consider, a national database and a national referral centre. All right? So a dramatic upward trend. And even this year, we're going up to 800 cases. And going on from that, showing the overall diagnosis. This is from the earlier database work done with Aurele Fabre, who now works in Dublin, looking into sudden death there. You can see that the valve disease, what I'm talking about, will emphasize, makes up 3% of the sudden deaths. That's a mixture of aortic and mitral valve disease, right? And even in our more recent studies, right, again, you can see that valve disease is making up 3% as well. So a not insignificant cause of sudden cardiac death. Now, here I'm concentrating on the mitral valve. You've got a nice smooth anterior and mural posterior leaflet. No bulging, no thickening, nice, even leaflets. And when you open it up at autopsy, there is the anterior like an apron, mural leaflet, chordae and papillary muscles. And here's the histology, the fibrosa, spongiosa, and here you've got the ventricular layer and the atrial layer. What about aging? This is a big issue for pathologists where we can actually come to problems in interpretation. As you age, particularly, well, it depends. As I get older, I get more and more aware what you mean by old age. Yes, exactly. But over the age of 40, I'm afraid, your mitral valve starts to sag just like the rest of you, unfortunately. And you get bulging between, right? And you get slight chordal stretching. This is a normal aging effect. And this is important because pathologists can misinterpret this as being significant. And as the work you may know with Michael, which Michael has done, on sudden death with autopsy findings of uncertain significance. There can be a potential for erroneous diagnosis, which was published in Circulation. And you can see here this mild floppy focal change, seen in anybody over 40. In our study, it showed that when you look at the valve, the different entities, right, you will find that what pathologists thought was a floppy mitral valve, we put into the normal group when we looked at the heart after the heart being sent to us. That valve I interpret as being an aging effect, not a significant floppy mitral valve. So there can be overinterpretation by pathologists of the significance of floppy change in an aging mitral valve. And as he showed, follow-up of these floppy mitral valve showed that the Brugada syndrome is what was found in these cases. So in other words, channelopathies can be present when you've got this particularly a mild floppy change. And this is what I train pathologists about. What do I mean by a significant floppy change or prolapse mitral valve? And that's very important to signify that if you've got bicuspid valve or if you've got a floppy valve, you will screen for channelopathies particularly, but also cardiomyopathies. It's a common valvular abnormality, as you can see, affecting 2 to 6% of the population. And even in the autopsy series, it goes 4 to 5%. But obviously, there's controversy over what ye clinicians mean by a significant prolapse, and what do us pathologists also mean by a significant mitral valve prolapse at autopsy. As you know, complications are well established of regurgitation with cardiac failure, ruptured cardiae leading to severe infective endocarditis, and ischemic events, right, with thrombi in a dilated left atrium. But what about the significance of the floppy mitral valve with true sudden death, where they've previously had very mild or no disease or asymptomatic? This is the issue we're talking about. And in our database, of 3,684 hearts who suffered death, we got 114 cases, 3.1%, which I already told you about, exhibited mitral valve prolapse. There was a comprehensive macro and micro examination of these cases, but it showed that 52 cases, right, nearly half, not quite, had concurrent abnormalities that provided an adequate cause of death. In other words, cardiomyopathies, particularly HOCM, ARVC, congenital heart disease, aortopathies as well. When you have a dilated aorta, severe hypertensive heart disease, ischemic disease, myocarditis, that you have a cause of death. And one case had mitral valve prolapse with acute chordal rupture. And this is an example where you get chordal rupture causing sudden death. But we concentrated on where there was just the changes in the valve without chordal rupture. And these were 62 cases of isolated mitral valve prolapse. 33% were male, 29 female. Mean age of 37, right? But 65% were under the age of 40. In other words, the age-related changes we're not worried about in this population. Ethnicity was predominantly Caucasian, with only one Afro-Caribbean, one Asian, and unfortunately unknown recorded in 8 cases. And the BMI, right, the mean body weight was 72 with BMI of 23, so no link to obesity. 46 cases, the majority occurred during rest or sleep, 4 during emotional stress, and in 9 cases during exertion, which is related to sporting-related events, and unknown in 7 cases. And 11 reported symptoms, in other words, a minority before the sudden cardiac death event, syncope, dizziness, palpitations, chest pain, and stomachache. 21%, 34, had an established diagnosis of mitral valve prolapse, which was considered insignificant, including 8 with arrhythmias, right? 10 others had a history of cardiac arrhythmias, but no history of mitral valve disease prior to the autopsy. So 18 patients with arrhythmias had atrial fibrillation, 4 ventricular arrhythmias, 1 supraventricular tachycardia, and in 7 cases, although an arrhythmia was recorded by the family, we did not get details of what that arrhythmia was, showing the lack of clinical details that we can get, because these are referred from all over the United Kingdom. And 3 cases, which I'm sure Matey will be interested, had a previous diagnosis of Marfan syndrome. 3 women were pregnant, in other words, pregnancy-related sudden death, and 6 cases were athletes. So, and looking at the heart macroscopically, 8 cases had atrial enlargement, 13%. The circumference was increased in 40%, greater than 10 centimetres. The mean heart weight was 414 grams, right? 334 in the females and 488 in the males. The heart weight was increased, and as Gerardo already told you, greater than 400 grams in females, greater than 500 in males, in 60%. So the heart was increased, but interestingly, a normal wall thickness in the majority. But there was left ventricular dilatation in 8 cases, with a diameter of greater than 35 millimeters. And what's important is that macroscopically, when I looked at the heart, there was no obvious scarring or fibrosis that I could see in the heart itself. All patients had thickening and ballooning between the chordae of both mitral valve leaflets with prolapse up into the left. In other words, I could see it going up into the left atrium. I always look at the left atrium before I cut into the valvular apparatus. Grade 3, according to my predecessor, Mike Davis. Elongation of the chordae with thickening, but no chordal rupture to explain the sudden death, and no obvious complications of infection or thrombosis. And here's an example of what I mean. Looking and opening up the dilated left atrium, as I say, in 11%, the valve, all of them, you have P1, P2, and P3, A1, A2, and A3, all prolapsing up towards me into the left atrium. Here again is prolapse, quite involving 2 of the 3 segments. And again, a close-up of the thickened prolapse anterior and posterior leaflet again. And on opening up, you will see that the generalized thickening of the whole valve leaflet, anterior, posterior, all involvement extensive, not just focally. Right? Again, thickening anterior, posterior. So in other words, you've got to have real pathology that jumps up at you at autopsy. Right? And that you're quite happy is significant. Now, histology of the leaflets show the pathology. In other words, they're thickened. There's a lot of fibrous tissue, which is here in red. Here's the zona fibrosa, but look, massive fibrous overlays occurring. The blue is the mucopolysaccharide increased deposition that one sees within the valve leaflet, and this highlights the mu-alcium blue mucopolysaccharide, which destroys the fibrosa, leading to the ballooning of the leaflets. Now, this is important. We looked at the papillary muscles and we looked at all aspects of the ventricle and the posterobasal wall in particular. And here, emphasizing anterior, posterior, and all aspects of the circumference of the ventricle. And what we found is that 56 of our cases, 75%, had microscopic fibrosis involving the posteromedial papillary muscle and posterobasal wall. But in addition, 12 cases, 26, had localized to this area, while in 30 cases the fibrosis was also present in anterolateral papillary muscle and the anterolateral wall. And 4 cases, interestingly, showed isolated involvement of the anterolateral papillary wall, anterolateral muscle. And this is what we see. This is the papillary muscle. Here's the fibrous tissue extending into the inner wall. It wasn't transmural, it was just the inner wall of the posterobasal wall of the left ventricle. And the fibrosis was mainly fine and interstitial, involving individual myocytes with focal replacement, but it was never large areas of replacement that you could see by naked eye. And here again, emphasizing the focality of the actual delicacy of the fibrosis that can be seen, which is a substrate for arrhythmia. So finally, myocardial fibrosis in 74% of cases, seen at autopsy, most commonly in the posterobasal, papillary muscle, and posterolateral left ventricle. It doesn't match a particular type of cardiomyopathy. There was no myocyte disarray, no widespread fibrosis, no of the pattern of ARVC. So, may indicate that mitral valve pro is a common final pathway in response to underlying cardiac disease. Was the fibrosis there first and then the prolapse, or vice versa? And as we know, fibrosis is a common and potent cause of cardiac arrhythmias. And here's the work done by Cristina Basso and by Domizio. This is an excellent, just published last year, on what they call arrhythmogenic mitral valve prolapse and sudden cardiac death. And this nicely combined the clinical findings with the pathological findings in 42 cases, highlighting similar findings at autopsy. Ye did find, I'm sure Domizio found fibrosis in all their cases, whereas we did not find fibrosis in a good 20% of our cases, roughly. But it matched, you can see the pathology is exactly the same, both leaflets, dilated atrium. In addition, previous ECGs could be looked at with their arrhythmias. And also prospectively, they could look at cases with mitral valve prolapse, particularly young women, in which arrhythmias could be seen, and also, right, late gadolinium enhancement in the posterobasal wall of the left ventricle in association with this. So a beautiful study combining the living clinical and the autopsy as well. So it's a significant cause of sudden death, 3% in our study. Mostly females. In the Italian study, we had a male predominance, and again linked to the arrhythmias. And the hallmark of arrhythmogenic mitral valve prolapse is fibrosis in the papillary muscles and infrabasal left ventricular wall, although we found it also in the anterior wall. And is this caused by myocardial stretch, by the prolapsing leaflets and elongate chordae, or is it the other way around? Is the fibrosis there first and the actual mitral valve change is secondary? We simply don't know. So abnormalities of the myocardium. Fibrosis is the most common in these two studies. A link to a possible underlying arrhythmogenic cardiomyopathy of a type we cannot really characterize. And the floppy change may be secondary to this cardiomyopathy, or is it primary? And finally, we need further collaborative studies. We'll answer this question, I think, both pathologically and clinically. Thank you.